Welcome everyone to PAVE Spotlight series. This series aims to uncover critical topics in Alzheimer's disease, and it aims to foster discussions on some of the key challenges in diagnosis and care, and propose ways research can provide elements for solutions for both the healthcare systems and for societal burden of the disease, and ultimately for improving the outcomes for those who are affected by the disease and their loved ones. Let me frame a little bit who is PAVE, who we are as a group. Project Alzheimer Value Europe is a coalition dedicated to accelerating progress in Alzheimer's disease, access to innovative diagnostics and therapies. And through collaborative research and external engagement efforts, such as this webinar, we bring together a diverse network of stakeholders that really tackle the challenges related to value and access decisions. And our members span from industry leaders, research institutions, patients advocacy groups, ex-payers. Together, we provide invaluable insight into healthcare solutions, including policy, economics, and resource allocation. And I encourage you all to visit our website for more information on PAVE, to learn more about our research publications, upcoming events, and opportunity for involvement in research with us. Today, we will talk about the huge burden that Alzheimer's disease poses on people, society, and healthcare systems. And we will also hear realistically, based on current research advancement, how important it is early detection and timely and accurate diagnosis to identify those individuals who could benefit most from innovative treatments. As we all know by now, that the opportunity to prevent or delay the cognitive decline due to Alzheimer's disease lays in the detecting and treating earlier than is common today. And the gaps and the barriers in the current environment for a timely and accurate diagnosis span from capacity, long waiting lists, reimbursement challenges. And we will hear something along these lines with a case study from one of our speakers today. And it is important to me that we keep reminding ourselves that having the necessary infrastructures and the right national guidelines to support a timely and accurate diagnosis will ultimately ensure that most appropriate patients are identified for future treatments and care. And blood-based biomarkers, which is another topic we will tackle today, hold the promise for non-invasive and cost-effective diagnosis. They can potentially change the way Alzheimer's disease is today diagnosed and even treated, and the landscape of Alzheimer's disease care in general. So we must ensure that innovation in diagnosis is also valued. To me, in order to keep people living with Alzheimer's disease in better health for longer, the healthcare systems must be equipped to accurately diagnose the disease earlier, enable regulatory approvals of innovative treatments in Europe, and provide prompt access to treatment and support. And I think keeping these as an ultimate goal, at the end, I want to just leave you with the next session, hoping that PAVE can give a contribution to the advancement of knowledge that will serve decision makers and policymakers to make informed decisions about future innovation in Alzheimer's disease. So I'll leave the floor now to Professor Lutz Frohlich to kick off the next session. Lutz, to you.
Yes, thank you, Laura, and hello everyone who's online here. My name is Lutz Frohlich. I am a geriatric psychiatrist and a professor of geriatric psychiatry at Heidelberg University in Germany. And I've been working in the field of clinical and applied Alzheimer's research for the last 30 years or so. In the upcoming slides, I will show you some data on epidemiology with a particular focus on early phases of Alzheimer's disease and on the relevance of biomarkers in this epidemiological context to most of us who are active or interested in the field of Alzheimer's disease, we all know that Alzheimer's disease poses an enormous and growing burden to the societies, both in terms of real psychological burden and, of course, in cost as well. In a recent analysis among a group of epidemiological and clinical researchers in this PAVE group, we have taken a detailed look at the epidemiology. And as you can see here, we all know that there are very many people affected by Alzheimer's disease and dementia, the syndrome, in all over the world and in Europe too. So the numbers say that 55.2 million sufferers exist globally, and about 9 million dementia sufferers are there in the EU countries. And we all know that due to increasing life expectancy and increasing also survival with Alzheimer's, with dementia, these numbers are continuing to rise. It is important to note that estimates say that approximately 2/3 of patients with dementia do have Alzheimer's dementia. And then in the final end, this raises really high costs of the disease-related costs. And as you can see here from the numbers, these are enormous figures, both in terms of direct as indirect cost. It's important to note that the largest part of patients with Alzheimer's disease and Alzheimer's dementia, Alzheimer's disease takes place before the dementia stages. So according to this ATN framework, which is a sort of a diagnostic framework, not only for research, but also for clinical diagnosis, we can distinguish within what is called the Alzheimer's disease continuum several different phases or stages. They range from asymptomatic subjects who only have pathological or biomarker-based evidence of the disease pathology to severe dementia, as you can see here. And the time ranges for each of these phases or stages is quite different. And you can see that the pre-dementia stages of Alzheimer's disease are ranging for across about 20 to 25 years, and the dementia stages range between 7 to 11 years. So these pre-dementia stages are difficult to assess in epidemiological studies, and usually they are not included in the estimates of the size of the AD population when you turn to epidemiological data. And on the other side, it is also a problem for epidemiological estimations that sort of the diagnosis of Alzheimer's disease as the sort of underlying etiology of dementia is usually not confirmed by biomarkers. We are trying to condense these biological and epidemiological data to make estimates which are related both to the different phases and to the real sort of biologically determined etiology. It is clear, and we all know, that Alzheimer's disease prevalence increases with age. We have a number of additional risk factors, as you can see here. But when you look at the graph here, you see that the gray and the reddish column parts of the bars really indicate that the non-dementia stages of Alzheimer's disease are really the majority. And we all see that there is a steady rise with age among all of these stages. There's a tendency that women are more affected with Alzheimer's disease. This may mainly be related to life expectancy. Women have a longer life expectancy, but there also might be sex-specific pathophysiological risks which lead to a higher occurrence and incidence of Alzheimer's disease in the female sex. And you can see here that there is a large proportion in younger ages in of course, in the pre-dementia stages. This is natural when we think of Alzheimer's dementia as an age-related disease. When we're looking at different regions across the world and compare the high-income and middle and low-income countries, we sort of see as a reference on the small insert, we see how the distribution of Alzheimer's disease between men and women and across ages is across the world. So we have a high number of people in younger age affected by mainly mild and asymptomatic stages of Alzheimer's disease. But of course, in Europe, with this with these aging societies, you see there is a shift towards more to the right side of the numbers. So there in Europe, there are relatively more subjects with Alzheimer's disease in higher ages. So this is the general tendency in all aging societies. Now have a look at the different stages of Alzheimer's disease within that Alzheimer's continuum. You can see on this table that the subjects with Alzheimer's dementia really are not the highest number population. So subjects with prodromal Alzheimer's disease, which means persons who have memory impairment but still functioning mainly unimpaired and autonomous in the community. Those subjects with prodromal Alzheimer's disease are more than double the size as compared to the patients with dementia due to Alzheimer's disease. And still, even more, the people with preclinical Alzheimer's disease, meaning just biological indicators of the pathophysiology, but no symptoms at all, objective symptoms at all. They even have quite a large, really quite the largest majority of subjects with Alzheimer's disease in the community. Especially these subjects with preclinical Alzheimer's disease are important targets for preventive measures. So maybe lifestyle changes or non-pharmacological prevention is really targeting towards subjects with preclinical AD. And subjects with prodromal AD and mild AD dementia are really the key target populations for disease-modifying, mainly anti-amyloid treatment, which are available in some countries of the world and at the door in others. When we think of the potential target population of subjects with prodromal or mild Alzheimer's dementia, so the key target population for anti-amyloid treatment, the question really is how many of those subjects in the community might really be eligible for these very specific and very sort of complicated to apply treatment options. And we have made some estimations coming from epidemiology, and you see some sort of two funnels, subjects with mild cognitive impairment and mild dementia. These estimations have been done for my country, Germany, and you start out with the prevalence in the society, and then you estimate and relate this to the share of those people who really do have amyloid pathology as the main key feature for Alzheimer's pathology in the brain. And then you really have to consider how many of those subjects really come into medical treatment or in a medical context, which could be potentially identified by doctors, by specialists too. And thus it means that from a number of 55 million people in Germany over in the aged population, really only 125,000 to 185,000 subjects might be potential candidates for these treatments. So this is really to show that these treatments is not for everyone, and there's a strong sort of preponderance for early AD. And then when you consider more specific inclusion and exclusion criteria, which have been set out by these clinical trials of these anti-amyloid treatment antibodies, the potential size of the potential number of patients who are really sort of could receive anti-amyloid treatment really boils down to 6.5 to 15,000 patients at all. So this is, I think, quite an important indication that the high prevalence and the specific treatments do not match up so well. That's it for here.
Yeah, thank you, Lutz, and happy to take over. My name is Sören Matke. I'm a professor at the University of Southern California, and I study how healthcare systems could deal with patients with Alzheimer's disease, in particular the diagnostic process. And today I want to run you quickly, very quickly, because Sweden is published and Germany will be soon, through our estimates, how long people would have to wait for a diagnosis in these healthcare systems. And this is a as good as it gets analysis, right? Like Germany has historically had a very well-resourced healthcare system, one of the largest number of like doctors, imaging devices, hospital beds per capita. Sweden, as you know, is a leading nation when it comes to dementia and Alzheimer's research. You just need to calculate the number of peer-reviewed publications per capita relative to all other countries to see that point. So if we can't make it work in those countries, we can't really make it anywhere. And we have seen that even the high-income countries are really ill-prepared because this hasn't been a treatable disease for a long time. And so there wasn't really an ecosystem that matched the prevalence of the disease because the value of an accurate diagnosis was somewhat limited by the absence of a disease-modifying treatment. But we also need to understand the degree of mismatch and also the sort of the sources of the mismatch between supply and demand for policymakers now that we are getting to EMA ruling on the disease modifying. Next slide, please. So this is a simulation model, it's a Markov model that walks the patient through the journey of initial detection in primary care, specialty consultation to confirm cognitive impairment, early stage biomarker testing, indication. So it's basically the top of the funnel that Lutz just showed you. So before we get to, is this a treatment candidate or not? Also, I think the number is actually slightly higher than what he said, because in real world, I don't think we can go by the strict inclusion-exclusion criteria from the clinical trials that included, for example, like patients with low education and comorbidities and whatnot. So I think the numbers are going to be a bit higher, but even if they are in that range, we still need to diagnose people whether they are eligible or not. We can't tell that upfront when they show up at the primary care office. So we had to go by expert input when we defined the assumptions for care-seeking behavior along the diagnostic funnel, because we don't know, right? This treatment isn't available in Europe, so we have no empirical data. And you can see that Germany and Sweden, the assumptions were actually quite similar. In both countries, you would start at 60 with no upper age limit. The annual screening rate in primary care would be 20 or 30% for those who have never been screened, about 10% for those who had been screened negative before. And then the referral rates differ a bit. So of those who get picked up in primary care as potential early stage cognitive impairment to a specialist is 58% in Germany, and the estimate was 80% in Sweden. So a much higher referral rate in Sweden. But then for the decision to do biomarker testing, if the patient is confirmed early stage decline, is pretty similar, 80 and 85%. Also, the proportion of tests done with CSF versus PET, 80% in Germany, very high with 90% in Sweden. And for our base case, we assume that no AD blood test is available. So here you can see the prediction for Germany. So in spite of the well-resourced health system, you can see the sort of the Bordeaux-colored bars. Specialist wait time reach at peak about 30 months. Biomarker testing even higher, so you get a cumulative wait time of like 60 months, give or take. And it's about 50-50 between wait time for specialist visit versus wait time for biomarker testing. Next slide. If you look at Sweden, you see on average pretty similar wait times, close to 60 months, and it's almost all because of wait time for a specialist visit. The very short wait time for biomarker testing is, of course, due to the fact that it is overwhelmingly done with CSF test, but also due to the fact that people are held up in the queue to see the dementia specialist in the first place, so they don't even get there. So the constraint is less important. And then as an alternative scenario, we looked at what would happen if a blood test for triage, so not for confirmation, were available in primary care. You can see in Germany that wait times drop precipitously because of the aforementioned fact that about half of the wait time is due to wait time for biomarker testing. So we go to about 20 months, give or take, and still about half and half between specialists and biomarker testing. And then in Sweden, on the next slide, wait times almost disappear. So you have about just shy of a year wait time. And again, it's almost all wait time for specialist visits. So pretty dramatic effect if you use a blood test for triage. I want to note though, this is hard triage. So you only get referred if you have both a positive cognitive test like the Mini-Mental and a positive blood test. Other than that, you get handled in primary care. Of course, this is not going to be that strict in the real world. So people who have one of the two positive are still going to be referred. And so the predictions are sort of an extreme case, but it shows you how powerful these blood tests can be in addressing some of the shortages in the system. Of course, this is a model prediction, right? This is our best guess and a first stab at what is happening. Anecdotally, what you see in the US, we are not wrong. Like most of the memory clinics say that their wait times have now reached a year or more, and they have a long backlog. And the promulgation into more general practice, general neurology, general geriatrics has been very slow. So I think these predictions are actually not far off from what we will see with the introduction of a treatment. It's a very stylized patient pathway, and of course there will be lots of variation. We only looked at the diagnostic phase, and can expect treatment delivery and monitoring with ARIA and MRI is going to be constrained as well. And then there's an important consideration that we just looked at specialists as the constraining workforce. But there's a lot of other staff involved, technicians in radiology and nuclear medicine, primary care nurses, and so on. And by the way, we didn't have good enough data for mild dementia in these countries, so we did not include those. And this would also include wait times because about a third of the early stage prodromal cases that Lutz just mentioned are mild dementia. So both countries, even though they have a fairly well-developed healthcare system, are projected to have these long wait times. It's still better than what we see in England and the US. In Germany, the high density of AD specialists, which is the highest among the G7 countries, means that biomarker testing is the rate limiting factor. It's actually interesting because Germany also has quite a high number of PET scanners, but we learned that the constraining factor is indeed the technicians who can administer these tests. So they run the PET scanners actually at comparatively low utilization rates, just because they can't find enough technicians to do more tests. Then in Sweden, the heavy reliance and also the fact that it's well established of CSF testing almost eliminate the wait for biomarker testing. And of course, that also makes the blood test very attractive. So this needs decisive action because these are not countries where long wait times for elective specialty care is sort of a habit and pretty commonly established. So policymakers need to act, in particular in Germany, because of the policy that EMA-approved drugs are immediately covered at this price for 6 months. So once the ruling comes out of Amsterdam, the drug is available, and then the wait times become a real problem immediately. Whereas in other countries, the HTA process will buy policymakers some breathing room, but still not a lot of breathing room because it might take another half year until the drug comes to the market. So thank you for your attention, and I'm happy to answer any questions.
Now, sort of, we are having prepared 4 slides on when we consider all these data and what Sören has told about the access of patients to the specialist and primary care physicians. We'll discuss with 4 slides on the impact of this on the healthcare system on the more clinical level, actually. So within the European Alzheimer's Disease Consortium, we recently conducted a survey and developed a position paper on how to deal with all these requirements and the lack of preparation of the healthcare system. And some general considerations about diagnosis is especially in Europe, we want to ensure equal access to timely diagnosis and appropriate medical management. And so I think this will be quite a challenge with this type of anti-amyloid treatment. And we have heard about them in particular, let's say in countries like Germany, there might be a problem with the primary care providers, I would say. So the demand for developing reliable diagnostic procedures and potentially, as Sören has pointed out, the triage system for transferring the right patient to the specialist is really a demand. And we need reliable diagnostic procedures also at the level of dementia specialists. Yeah? So the whole point of identifying the right patients for this anti-amyloid treatment is really a challenge for most of the healthcare systems and also for the collaboration within different different physicians groups. So when a patient then arrives at a specialist, there is a lot could be said about how to obtain informed consent, because this is quite a tough treatment procedure with some burden. This is a new type of treatments for patients, and this is a long-term treatment also. So all these aspects really need to be explained in detail, and shared decision-making with these patients who are still able to make an informed consent is really one of the key features to ensure adherence and also to set the expectations of these. And you can see what details may be need to be discussed and also must be considered before starting such an anti-amyloid treatment. And in the next slide, you see when a treatment is initiated, the center where it is being done may be sort of not readily available everywhere and with every specialist physician. So it's really an infusion center setup which is required, in addition to some diagnostic procedures, specialist procedures like either biomarkers or positron emission tomography must be available on an easy basis in such a center. And one of the major problems is that during the treatment with anti-amyloid drugs, the regular MRI assessments should be performed to ensure safety of the treatment. So the particular drug-related side effects area are radiological phenomena primarily, and they need to be detected and watched out and appropriately handled in a clinical level. So there is quite a logistic required to schedule these MRI safety assessments over time, and of course there must be enough MRI resources available at all. And in the last slide, you see that this requires a lot of extra and new skills and experience, in both among the clinicians as well as with the technical physicians, in particular with a neuroradiologist. So we need this anti-amyloid treatment, and so this should be monitored and initiated by specialists. We need specialist MRI readers as well. We need both clinically and radiological experience to manage these ARIA phenomena. Thus, many educational activities need to be implemented and ensured that a patient is included in this educational sort of perspective of the treatment. Of course, the management of other anti-dementia drugs like the symptomatic cholinesterase inhibitors and non-pharmacological treatments should also be integrated, and social counseling should also be offered in this whole setup on the sort of at the best level. So the whole setup really needs to improve both quantitatively, qualitatively, and in the type of collaboration between different physicians. So this might pose quite some challenges. Thank you.
All right, thank you, Lutz. Lutz and Soren will be answering questions at the end of the session today, so please feel free to share any questions that you have for them on their presentations in the chat. Next, I will turn things over to Dr. Suzanne Schindler. Dr. Schindler is a clinical neurologist and neuroscientist who specializes in the diagnosis and treatment of memory disorders, particularly Alzheimer's disease. She leads the Global CEO Initiative on Alzheimer's Disease Blood Biomarker Work Group, which recently published performance recommendations for blood-based biomarker tests. I will share the link to that publication in the chat, and now I will hand it over to Suzanne.
Great, thanks so much for inviting me to participate. So I'm going to start out by defining some terms. First of all, what are biomarkers of Alzheimer's disease? As you are likely aware, cognitive impairment and dementia can be caused by many different conditions, not just Alzheimer's disease, but stroke or medications, sleep disorders, and many other neurological disorders. So in contrast, Alzheimer's disease is a specific brain disease. You can see in the lower right corner, that is a picture of Alzheimer's disease brain pathology. And you can see amyloid plaques and tau tangles. That is what defines Alzheimer's disease, not the symptoms, the pathology. Now, these two terms are often conflated, and that's because Alzheimer's disease, this pathology, is the most common cause of cognitive impairment and dementia in patients older than 65. So Alzheimer's disease often causes cognitive impairment and dementia, but there are many other causes that we have to think about when we're trying to diagnose patients. So what the role of Alzheimer's disease biomarkers is, how we use them clinically, is we try to find out whether patients with cognitive impairment and dementia have this Alzheimer's disease pathology in their brain that potentially could be causing or contributing to their symptoms. And there are three different types of biomarkers that we use clinically. So the first is amyloid PET. It's a specialized brain scan, and you can light up these amyloid plaques in the brain when you do this brain scan. We also do cerebral spinal fluid biomarkers. This requires doing a spinal tap, and then we collect some of the fluid and send it for analyses that tell us whether people are likely to have these amyloid plaques and tau tangles in their brain. And of course, now we have blood biomarkers that provide information very similar to what we get from the CSF biomarkers and amyloid PET scans. All three of these modalities are telling us whether these Alzheimer's brain changes are present or not. Now, it is becoming increasingly clear that these blood tests will play a major role in dementia diagnosis in the future. As Dr. Mackey was telling us, we think that this could really help us be more efficient in our diagnoses. This is particularly important because now, of course, we have 2 amyloid-lowering treatments that slow the progression of early Alzheimer's disease, dementia, and they have both been approved by the FDA. However, before we can prescribe them, we have to use biomarkers to demonstrate that amyloid levels are elevated. A drug that's mechanism of action is lowering amyloid is not going to help people unless they have elevated levels of amyloid plaques in their brain. We think that these blood tests are really critically needed tools. And this is because those traditional methods of biomarker testing that I mentioned, these cerebral spinal fluid biomarkers and amyloid PET scans, these are typically only performed by dementia specialists like me. And they have drawbacks. So a lot of patients are not excited about undergoing a spinal tap. Although I know in Europe there's seems to be less concern about that than in the US, but they still require specialized staff, and there's a lot of burden associated with that, and that they also are more expensive to perform. At least in the US, it often takes 6 months to 12 months to get an appointment with a dementia specialist. And since we're the only ones that are doing this biomarker testing, or we have been, this can really delay biomarker testing and thus diagnosis and potentially treatment. In contrast, primary care providers are very comfortable using blood tests. Patients are very comfortable having blood collected. So this means that we could potentially use these Alzheimer's disease blood tests much more widely and at the primary care level. And this could make an early AD diagnosis much more widely available and more timely. Because of these major advantages, the use of these AD blood tests is rapidly increasing in the US. So looking back 5 years before 2019, very few patients underwent biomarker testing, period. So not very many people got amyloid PET scans or CSF biomarker tests. And this was largely because we didn't have any disease-modifying treatments. Also at that point, there were no Alzheimer's disease blood tests that were clinically available. But times have changed, and now in 2024, we're using these Alzheimer's disease blood tests quite widely in AD research studies as well as in clinical trials. And this means that people are getting more comfortable with them, just more used to the concept of using blood tests. And now many of these blood tests have become clinically available in the US. And this includes tests from C2N Diagnostics, Quest Diagnostics, LabCorp, Lucent AD, Quanterix, AllsPath, and others. So there's a whole list of clinically available blood tests that we can use right now. There's also increased validation studies demonstrating that at least some of these tests, not all of them, but some of them really have high accuracy, really quite similar to what we see with our FDA-approved CSF tests. And because of this, more clinicians are ordering these blood tests and more patients are asking for them. However, there's still some barrier to these. In the US, insurance won't pay for these blood tests, or at least will just pay for them inconsistently. There's a lot of knowledge gaps in how to use these blood tests and how to interpret the results. There's also major variability in the accuracy of these Alzheimer's disease blood tests. Some are really good and some are not. And because there's variability in the accuracy of these tests, there's a perception by many clinicians that these blood tests are inaccurate or untested. So to address this concern, the Global CEO Initiative convened a work group to define the acceptable performance of these tests for use in clinical care. And we published a consensus statement just last month. You can see that in Nature Reviews Neurology. And this effort really required bringing together a large and diverse group of stakeholders to agree on how to use these tests. So there are many different issues discussed in this paper. So I'm just going to highlight one key element, which is that we agreed upon performance standards for two types of AD blood tests. For triaging tests, which are used to rule out amyloid pathology, we agreed that the test must have greater than 90% sensitivity and greater than 75 to 85% specificity for amyloid PET status, depending on the availability of follow-up testing. Now, for triaging, a negative test identifies individuals who are unlikely to have amyloid pathology. So the key thing is it's finding the people who don't have Alzheimer's disease pathology. Now, a positive test identifies people who have a higher likelihood of having amyloid pathology, but it's not supposed to be the final word. So you're supposed to have a second test to confirm the presence of amyloid pathology. For confirmation of amyloid pathology, or ruling it in, we agreed that the test must have greater than 90% sensitivity and specificity for amyloid PET status. And we chose this because this is the performance that we see for FDA-approved CSF tests. So really what we're saying is that the blood tests need to be as good as the CSF tests. For confirmation, the negative test is identifying people who are unlikely to have pathology, and a positive test is identifying people who are likely to have pathology. And I would note that the way that you use these tests also depends on the person you're testing, what we call a predictive value. And the paper goes into more depth about this. I would note that although the standards we set were high, some of the currently clinically available blood tests meet these performance standards. So this is exciting. We think that it's quite reasonable to use these tests in clinical care. It does still require some expertise, however. So in conclusion, there is, I think, very little or no doubt that these Alzheimer's disease blood tests are the future of dementia diagnosis. There are some remaining challenges, though, especially knowledge gaps in how to use these tests and interpret the results. We really have a lot of work to do in educating clinicians about these areas. However, I think we're making significant progress. So I think at this point in 2024, we've moved past the phase where these blood tests are being used by a tiny number of innovators. And I think things are really starting to pick up. I think we're now in the phase of change where there's increasing numbers of early adopters. And I think that spurred by the approval of new treatments, there's going to be greater and greater use of these AD blood tests over the next few years. I'm excited about this because I think integration of these blood tests into clinical care may enable many more patients to access an earlier and more accurate diagnosis. And that's really required for access to new treatments. So thanks for your attention, and I'd be happy to take any questions during the panel discussion.
Perfect. Thank you, Suzanne. We've covered a lot of ground today, from the potential of blood biomarkers to the broader implications of diagnostic and treatment advances for healthcare systems. I'm excited to open the floor for questions. We have about 13 minutes for questions in the latter half of this webinar. So we have some excellent questions for our experts, and I'm sure there are many more on your mind. So please share those in the chat, and let's dive into the Q&A session. First, a question back to you, Suzanne, quickly. In the complex Alzheimer's research landscape, how does multi-stakeholder collaboration play a critical role in ensuring new therapies and diagnostics are not only clinically effective, but also demonstrate value to both regulators and healthcare systems, ultimately leading to patient access?
Well, this is a really big and really important question, and it's something that we've been grappling with a lot, just as we're trying to get these new diagnostics and treatments to patients. Because frankly, we spend a lot of time and effort developing these diagnostics and treatments to help patients, and they're not doing any good if we can't get them into patients. And this is really challenging. And I think the fuel that's really driving this is really the need of patients and their caregivers for these new diagnostics and treatments, that these things have not been available. And even though they now exist, they're not widely accessible. But I think the patients and their caregivers will drive us forward. It's important that we listen to them and hear their voices. But to actually get these to patients, we all have to work together at multiple different levels. We have the research community that's developing these diagnostics and treatments and validating them. But they need to also work with companies that are commercializing them, that are marketing them, just so that everybody's doing everything appropriately. As we've experienced with the blood tests, it's important not that they're developed, but we know how good they need to be and how they should be used. We also need to think about the broader healthcare issues, such as what Dr. Mackey was talking about in terms of how do we implement these effectively, and what tools should we use? How do we use them to bring this to patients? And then we have to get insurers to pay for them. And we have to demonstrate to payers that this is a good deal for them. So there are just many levels of challenges. So we all need to talk together and work together to make this happen. This is really going to require efforts at many different levels. So I encourage everybody to try to do their part to make this happen.
Right. Thank you, Suzanne. Lutz, I'm going to turn it over to you and move into a question about the potential benefits and challenges of early detection. Soren, too, please feel free to chime in. I think you could provide some perspective on this question. But Lutz, what are some of the potential benefits of early detection for patients with Alzheimer's disease and their care partners? Then, considering these benefits, how might the ecosystem for adopting blood biomarkers evolve in clinical settings?
Yeah, as Suzanne said, this is really a big challenge for all physicians' specialties involved, yeah, and to really provide value for patients, meaning best possible diagnosis, best possible treatment at least cumbersome or least inefficient workup, and potentially also least cost possibly, requires dense collaboration within different levels of the healthcare system. So in particular, for applying these anti-amyloid treatment, there must be really a new and a dense collaboration between radiologists, specialist clinicians, neurologists, also social services potentially involved there too, and these infusion center resources. And of course, this only is manageable when the PCP really sort of can transfer patients potentially via biomarker triage, more or less well prepared to this specialist setting. So this is, I think this is quite a huge effort, but it has been managed in other diseases, in particular for neurologists in the field of MS. This is part of the normal workup for this long-term treatments and chronic disorders. But the Alzheimer's field is particular because of the high number of patients and the aged population with the questions of multimorbidity. So a number of new ways of collaboration have to be established.
All right. Thank you, Lutz. We're going to return to that topic in a second, but I did see a question come up in the chat that I think Suzanne can answer. So the question is, when we consider the application of blood biomarkers to primary care as a triage test, do you anticipate problems in interpreting the test results and actually overwhelming the referral process to dementia specialists as a result? This specifically is with regards to the consideration that they are not confident in their clinical diagnosis of cognitive impairment using tools such as MMSE.
So that's a great question. And that is something that we discussed a lot with the triaging tests in particular. And that's why we set a higher threshold of 90% sensitivity and 85% specificity for clinics where there was less certainty that they had access to confirmatory tests like CSF testing and amyloid PET, so which is really primary care. So in other words, the blood tests need to be really good, and they need to be pretty specific if you're using them in a primary care setting, or else you will end up with a lot of false positives. And a lot of false positives really could swamp dementia specialists. We're already overwhelmed, and so if there's a lot of false positives coming in who really don't need to be seen by us, that could create certain really major problems. So, and that point specifically is discussed in the paper with some calculations about that. But I think that one role that dementia specialists are going to need to fill going forward is educating general neurologists and primary care docs about how to use these tests. And that's going to be a process that takes some time.
Now we probably have time for one or two more questions. So Lutz and Soren, how can we ensure equitable access to early detection tools for Alzheimer's disease, considering disparities in healthcare access across different socioeconomic demographics?
I think this question is really difficult to answer. Yeah, I mean, in the European countries, we have a healthcare system which is mainly based on solidaric principles. So, in generally, all patients, more or less, at least in the higher income European countries, feel they are entitled to the best possible treatment everywhere at no extra cost. Yeah, so this co-payment thinking, which is prevalent in the US, is not something which is sort of part of the European system, more or less. And still, I mean, because of the technicalities there is, and the access to infusion centers, this is a strong limitation. Yeah? So I think this is a demand for to ensure to sort of more to work for equal access, I would say. But we must admit that this may pose sort of inequality within regions, with more within regions in the European system than with income factors or so. But so this will be a continuous process to improve this. Yeah.
Okay. Awesome. Thank you, Lutz. And in the final minutes, I'm going to turn it over to Soren to answer one question, continuation of the discussion of some of the challenges for healthcare systems with the introduction of these tools. So how can we balance the increased demand for resources with ensuring timely and effective care for a larger population diagnosed with Alzheimer's? What strategies can we implement to optimize resource allocation and support specialists in this new landscape?
Yes, so for starters, I would say, at least in high-income countries, there was never really a problem absorbing new therapies, even though many new therapies were initially sort of met with alarmist concerns about this will bankrupt us. If you look at the hepatitis C drugs, if you look at innovations in cardiology like transcatheter aortic valve replacement, healthcare systems adapt. I think at the moment, of course, with economic growth stagnating and healthcare costs increasing, it becomes harder to make such sort of things by squeezing it a little bit here and a little bit there. But in the end, I think this is not going to be a situation in which the sky is falling. Right? Like Lutz has shown how steeply the funnel narrows when you go from the overall population that may have the Alzheimer's pathology to the ones that are actually treatment eligible. And while I think the number is a bit low, I mean, this still gives you a perspective that, yeah, maybe like 50,000 people in Germany. So it's not going to be a disaster for the healthcare system to handle that. It's going to be difficult just from an infrastructure perspective because we are not prepared to do it. But I'm not convinced that this is like a fundamental challenge to the sustainability of these systems.
All right, and with that, I want to thank everyone for joining us today. We appreciate your interest in PAVE and in advancing solutions related to diagnosis and treatment of this devastating condition. A recording of this webinar will be available on PAVE's website soon. So we really appreciate you joining us today and hope you have a wonderful rest of your day. Thank you.